Good afternoon and welcome to our session today. Today's session is the latest on the treatment of status epilepticus, and we're excited to have you joining us. We have 3 talks today, and these are by Dr. Jaideep Kapoor, Dr. Cecil Hahn, and myself. And I'll be introducing the speakers between each talk in a little bit more detail. I'm introducing myself actually at the beginning of my talk. At the end, we will have a question and answer period. And we may be able to go into one of the meeting spaces afterwards if there's any further questions. So without further ado, we can begin with my talk. And I'll be speaking about basic science principles underlying the treatment of status epilepticus. Definition of status epilepticus to review. Good afternoon. My name is Tennille Gofton. I'm an associate professor in the Department of Clinical Neurological Sciences at the Schulich School of Medicine and Dentistry at Western University in London, Ontario, Canada. Today, we'll be talking about some of the basic science principles underlying the treatment for status epilepticus. With regards to disclosures, I have research grant funding from the following agencies, and I am the principal investigator for the Norse Virus Family Registry. Today's objectives include briefly reviewing the definition of status epilepticus, to review and outline some of the pathophysiological mechanisms underlying status epilepticus, and to talk about some potential therapeutic targets for treatment in status epilepticus. So to begin with, the most up-to-date definition for status epilepticus comes from the International League Against Epilepsy and was published in 2015. This is a definition stating that status is a condition resulting from failure of the mechanisms responsible for seizure termination or from the initiation of mechanisms that lead to abnormally prolonged seizures. It's a time-based definition, including a T1 and a T2 that are important because after T2, we will have long-term consequences from prolonged seizures. The 2 important operational dimensions that I talked about include T1, which is the length of the seizure or the duration after which it's considered to be a prolonged seizure, and T2, which is the time after which an ongoing seizure will result in long-term consequences for the individual. This definition applies to all types of seizures, but for the purposes of today's talk, we'll be talking about convulsive status epilepticus. The important aspect of this definition is the fact that it is time-based, because we all know time is brain, and the faster we treat seizures, the better outcomes we have. When it comes to convulsive status epilepticus, it is a condition that results from failure of the mechanisms intended to terminate seizures and initiation of the mechanisms leading to abnormally prolonged seizures. It may be one, it may be the other, or it may be both. In convulsive status epilepticus specifically, T1 is 5 minutes. At 5 minutes, a convulsive seizure is considered to be abnormally prolonged, and T2 begins at 30 minutes. After this time, we're likely to see longer-term consequences from sustained or persistent seizures. Pharmacoresistance develops over time, and there's a reduced response to anti-seizure medications. So the longer a seizure goes on, the harder it is to treat. When we think of normal seizure termination, there are many processes involved. Neurotransmitter depletion occurs. So there's depletion of glutamate, which is neuroexcitatory. There's ATP depletion and ionic changes. So with a seizure, you get increased calcium and sodium influx and potassium efflux from the cell. There's also acidosis in the extracellular environment and increased GABAergic drive that assists with inhibition. There also may be release of adenosine and other important peptides. Electrically, we think of spatial and temporal synchronization. So during a seizure, we see increased spatial and temporal synchronization, and this usually is maximum right before termination of the seizure. Status epilepticus itself, rather than a spontaneously terminating seizure, is a dynamic process, and this postictal state can't be reached. And the brain flickers between periods of cessation of synchronization and periods of synchronization when it is unable to transition to the postictal state and remain there. Faulty seizure termination comes into play at T1 or 5 minutes and when we develop a prolonged seizure. There's failure of the critical transition from the ictal to the postictal state. And looking at this from the point of view of a picture, in a normal seizure, the brain transitions from an ictal state, going through the transitions that are required into a post-ictal state. In an abnormal brain, there's transition or flickering that occurs as the ball tries to get over into the post-ictal state, but is unable to remain there and comes back to the ictal state. In other words, the mechanisms that are favoring the seizure state are outweighing the mechanisms favoring the post-ictal state, and sustained seizures occur. During the early period of status epilepticus, there are acute receptor changes that occur, and this usually happens between T1 and T2. GABA A receptors are internalized into the cell, making it harder for benzodiazepines to work. NMDA receptor expression is increased in the postsynaptic neuron. Adenosine or A1 receptors are reduced, as well as GABA B receptors, and AMPA receptors have loss of the GLU-A2 subunit, and this results in calcium accumulation and potentially neuronal cell death. There's also an increased expression of drug transporter proteins in the cell membrane, leading to increased extrusion of drugs from the cell. All of these mechanisms together contribute to that developing pharmacoresistance over time. During the time between 5 minutes and 30 minutes, or T1 and T2, we also have mechanisms that support ongoing seizures. These include breakdown of the blood-brain barrier that allows albumin to leak into the spaces where it is not usually contained. There's inflammation, including cytokine and COX-2 or prostaglandin pathways. You have increased interleukins, specifically interleukin-1, interleukin-6, and TNF-alpha, as well as microglial activation. There can be increased expression of pro-epileptogenic peptides. And overall, there's persistent spatial and temporal synchronization from the point of view of the EEG and electrical activity. Prolonged seizures are harder to treat, and this is largely because of receptor internalization and an inability to access the appropriate receptors with the medications that we currently use. It happens for many reasons. There's internalization of GABA A receptors. This may be increased by activation of NMDA receptors that trigger a calcineurin-dependent process that also helps with GABA receptor internalization. There are also changes in the phosphorylation state of the KCl transporter KCC2, which contribute to this process. Refractory status epilepticus is status epilepticus that does not respond to first and second line treatments, and usually the seizures last greater than 30 minutes. Super refractory status epilepticus are seizures that continue or recur 24 hours after the onset of anesthetic or continuous anti-seizure medication treatment, or that recur at the time of withdrawal of those treatments. These seizures occur usually because the underlying pathological process hasn't been fully addressed and continues to drive the seizures rather than supporting the post-ictal state. It may also be because pathological changes have occurred in the brain over the 24 hours of seizure that have set it up for a continued ictal state. In this case, again, we see that the red ball is unable to transition from the ictal to the post-ictal state. Past T2, or past 30 minutes, we see pathophysiological changes that can be permanent. These changes lead to neuronal death and death of interneurons, inflammation, and breakdown of the blood-brain barrier that allows albumin and toxic-related processes to occur. Altered network connectivity can occur in the brain, and there are also altered receptor, ion channel, and gene expression. Neurotransmitter release profiles also change over time. The most concerning or detrimental side effect of prolonged seizures is the neuronal cell death. So we see sustained neuroexcitation with prolonged seizures, and this will lead to hippocampal injury, as well as loss of neurons in the hilus, CA3, and CA1 regions. Altered calcium homeostasis or calcium disturbances will lead to increased intracellular calcium in the cell, but also within the mitochondria. Specifically in the mitochondria, this leads to free radical production, which are toxic to the neuron. Increased reactive oxygen species, as we talked about in the mitochondria, result in further dysfunction of the mitochondria, but also damage to the DNA of the cell itself. Systemic changes occur with all of these processes and lead to hypotension, hypoxia, and acidosis that may exacerbate all of the other processes we just discussed. We look for potential therapeutic targets in status epilepticus, and researchers looking forward have a lot of mechanisms that are being investigated. So we've talked about changes that occur with sustained seizures, and all of these mechanisms are potential therapeutic targets. When we think about inflammation or cytokine release and prostaglandins, being involved in those pathways, as well as reactive oxygen species. These are all potential pathways for intervention. Specifically, researchers are looking into anakinra and tocilizumab, among other substances that can target all of these pathways in an attempt to reduce the cytokine profiles or other inflammatory pathways. Altered gene expression and protein expression is a problem. Pathways that are downstream of the mTOR gene are thought to potentially exacerbate status epilepticus and lead to some of the downstream detrimental effects, and therefore inhibition of this with potential inhibitors may also be beneficial. Altered neurotransmitter release, we've already talked about when it comes to GABAergic transmitters, but there also may be dysfunction in cholinergic systems. So targeting cholinergic dysfunction with co-administration of medications such as scopolamine may be beneficial to help abort status epilepticus sooner. Oxidative stress is a concern that we talked about on many levels, both extra reactive oxygen species that are produced by inflammation, but also by the mitochondria with altered calcium homeostasis. So looking into antioxidants in various pathways that can be inhibited or blocked in order to reduce the generation of reactive oxygen species may reduce the collateral damage that occurs with prolonged seizures and may help improve outcomes. Blood-brain barrier dysfunction is another area of intense research. Right now, a focus is on looking at how one can reduce albumin-induced astrocytic activation and other processes that occur due to impaired blood-brain barrier function. Rational polytherapy is something that likely my colleagues will talk about in a little bit more detail, but the goal is to target many of the mechanisms we've talked about at one time in order to reduce status epilepticus or to stop it in its tracks rather than treating it sequentially. So one could co-administer inhibitors of NMDA and benzodiazepines at the same time in order to help enhance benzodiazepine effects. Calcineurin antagonists are another possible area that could be targeted at the same time as administering benzodiazepines in order to enhance their potency. Using inflammatory inhibitors such as an anakinra that we just discussed may also help improve benzodiazepine effectiveness. And strategies used to target other pathways such as GABA receptors outside of the gamma subunit containing receptors that are internalized, so the gamma subunit lacking GABA receptors may be targeted with anesthetics or neurosteroids, which may improve overall treatment responses. So in conclusion, there are pathophysiological changes that both support and propagate status epilepticus, and these occur over time. When we have faulty seizure termination and mechanisms promoting prolonged seizures, we set up for status epilepticus. Important mechanisms that support ongoing seizures include impaired GABA and other neurotransmitter signaling, abnormal extracellular environments, inflammation, and breakdown of the blood-brain barrier. Permanent pathophysiological changes can occur with prolonged seizures, including altered receptor expression, altered calcium homeostasis, and mitochondrial dysfunction, as well as neuronal cell death and DNA damage. And rational polytherapy is being investigated with the idea that we target multiple receptor systems simultaneously with the goal of stopping the mechanisms that are sustaining status and causing damage in the future. And with this, I'll conclude today and leave some time for questions. I thank you for your attention, and I look forward to our discussion. So now we'll move on with our second talk. Dr. Jaideep Kapoor will be doing the second talk, and I know for many in the audience, he will not require an introduction. But Dr. Kapoor is a Eugene Meyer Professor of Neuroscience and Professor of Neurology at the University of Virginia. He's also Director of the Brain Institute at the University of Virginia. He is multi-talented and he leads epilepsy bench and clinical research projects, specifically conducting large epilepsy research trials. He is also the recipient of many awards. Importantly, he was also the president of the American Epilepsy Society in 2010. So Dr. Kapoor will be talking about the treatment of non-convulsive and convulsive status epilepticus, and we will move on with that now. Thank you.
Thank you so much for joining us today. As you've just heard, status epilepticus is a neurological emergency with rapidly evolving EEG, and clinical changes. The treatment to status epilepticus also has to evolve with the evolution of seizures. Seizures modify the brain and its activity, and which further cause more seizures to occur. And our goal in treating status epilepticus is to terminate this cycle of seizures begetting more seizures. As you've heard, a key point in pathophysiology of status epilepticus is reduction in GABAergic inhibition early in the course of this condition. We can reinforce GABAergic inhibition using benzodiazepines. It's well established that diazepam and lorazepam can terminate status epilepticus. However, when you try to treat status epilepticus in the field, starting an intravenous drip to administer lorazepam is a challenge. There is a certain level of skill required to start an IV, and also it takes time. Robert Silbergleit and colleagues designed a clinical trial to test whether intramuscular midazolam would be at least as effective as intravenous lorazepam for the treatment of generalized convulsive status epilepticus. They conducted a randomized controlled trial where approximately 900 patients were randomized to either getting intramuscular midazolam or intravenous lorazepam. All patients received an intramuscular shot and an IV. However, half of them either got a placebo intramuscular shot or a placebo intravenous injection. As you can see from this chart, those receiving IV lorazepam had certain challenges. Some of them, IV was not started, while in others, seizures stopped even before lorazepam was given. In the end, approximately same number of patients were included in intention to treat analysis for lorazepam or midazolam, similarly for per protocol analysis. As you can see, the trial was designed for judging non-inferiority. That is, the investigators wanted to know whether midazolam was at least as good or effective as lorazepam. What they found was that midazolam was effective in somewhat more than 73% of patients, whereas lorazepam was effective in 63% of patients. Lorazepam just exceeded the non-inferiority margin. Thus, you could see that IM midazolam was at least as effective, if not more, than lorazepam. What are the reasons for these differences? Investigators looked at timing of the drug administration and found that time from active treatment to cessation of seizures was the same. However, the time from opening the box to initiating the active treatment was different for these two drugs. Lorazepam, it took 5 minutes to administer, whereas midazolam could be administered within 2 minutes of opening the treatment box. And this had consequences. More patients who were treated with midazolam were discharged from the emergency department to home, and fewer had recurrent seizures or required intubation. So midazolam is at least as effective as lorazepam when given intramuscularly, if not superior. However, you will see from this trial that approximately 1/3 of the patients did not respond to lorazepam or midazolam, ranging between 63 and 73% in efficacy. So we need second-line agents to treat benzodiazepine refractory status epilepticus, which is often termed established status epilepticus, where benzodiazepines have failed. An established status epilepticus treatment trial was a randomized, controlled, blinded trial to compare the efficacy of fosphenytoin, valproic acid, and levetiracetam for the treatment of generalized convulsive status epilepticus refractory to benzodiazepines. We chose these three drugs because they are most commonly used drugs for the treatment of status epilepticus. Fosphenytoin has been the traditional drug of choice, whereas levetiracetam is more commonly used now. And there are studies which suggested valproic acid may be more effective than these two drugs. There was concern that fosphenytoin can cause hypotension or cardiac arrhythmia when administered to patients in generalized convulsive status epilepticus. The study was conducted under exception from informed consent because meaningful consent is not possible when the patient is having convulsions, not conscious, and their family is extremely distraught, would not be able to understand risks and benefits of the study. Also, all three drugs are perceived to be equally effective going into the trial. The trial worked this way. A patient was seen to be having convulsions. Emergency medical personnel were called. Upon arrival on the scene, they witnessed the patient to be having convulsions also. They gave adequate doses of benzodiazepines while en route to the hospital. Upon arrival in the hospital, if the patient was continuing to have seizures and adequate doses of benzodiazepines had been given, they were then given one of three drugs, levetiracetam, valproic acid, or fosphenytoin over 10 minutes. Patients were observed for another 10 minutes for cessation of seizures. Patients were further observed for another 40 minutes for allowing recovery of consciousness. Patients were felt to have met the primary outcome if their clinical seizures had stopped and they had started responding to their environment or painful stimuli. Also, there was no other medication needed to terminate seizures over that hour. If patient needed to be intubated, they were considered a failure because we use sedative anticonvulsants such as midazolam to intubate patients. We randomized 400 subjects, somewhat more to levetiracetam than fosphenytoin and valproic acid. This is because the trial was designed as a Bayesian trial. And in the intent to treat analysis and per protocol analysis also, patients were balanced. With respect to age, there was balance between these three age groups, looking both at the mean age group and also at various age groups from 0 to 5 all the way to 61 and older. All three drugs were equally effective in terminating status epilepticus. Levetiracetam was effective 47% of the time, fosphenytoin was effective 45%, and valproic acid was effective 46%. If we broke down the analysis by intention to treat, or per protocol analysis, or adjudicated analysis, all three drugs performed equally well in terms of terminating seizures and improving responsiveness within 1 hour of drug administration. We also looked at age-specific outcome. We were very conscious of the fact that often drugs are not studied sufficiently in children, so there were enough children included, and we found exact same efficacy for three drugs in children from 2 to 18 years of age, younger adults 19 to 65 years of age, and older adults 66 and older. We also evaluated safety outcomes, and very surprisingly, we did not find increased incidence of life-threatening hypotension or cardiac arrhythmias associated with fosphenytoin. They were equally distributed among three drugs. However, very surprisingly also, endotracheal intubation within 60 minutes was much more common in children treated with fosphenytoin, but not levetiracetam or valproic acid. This was 3 times as much as other two drugs. The reason for this is poorly understood because fosphenytoin is not known to cause respiratory depression, and it did not do so in our trial. Also, other trials have not found similar adverse events with fosphenytoin. Other adverse events were similar for all three drugs in children. When we look at young adults, all three drugs performed equally well. There was no excess signal with respect to life-threatening hypotension, cardiac arrhythmia, respiratory depression, intubation, etc. in this age group. In older adults, more older adults given levetiracetam experienced death, but this was not statistically significant. Other adverse events were equally common amongst three drugs. So in summary, we tested three drugs, which are all anti-seizure drugs for termination of benzodiazepine refractory status epilepticus. All three drugs were effective. Approximately 50% of patients, they also had similar safety profile with respect to cardiac arrhythmias, hypertension, respiratory depression. The intubation rate was somewhat higher in children treated with fosphenytoin. One has to ask why all three drugs behave similarly. They're all anti-seizure drugs, that is, they terminate seizures. They do not terminate the underlying cause of status epilepticus. During status epilepticus, as I said earlier, seizures modify the brain, which then cause more seizures to occur. A key receptor in this vicious cycle is the NMDA receptor. Activation of NMDA receptor worsens status epilepticus in experimental animals. Blocking this receptor can terminate status epilepticus, especially when it is given with other anti-seizure medications. So in the future, we plan to test whether ketamine added to one of the second-line agents, levetiracetam, would be more effective than levetiracetam alone in the treatment of established status epilepticus. This would be suggested by experimental animals. Let me end by repeating that benzodiazepines are the initial treatment of status epilepticus. Midazolam, given intramuscularly, can be given rapidly, and it is at least as effective as intravenous lorazepam, if not more, without any more adverse side effects. Levetiracetam, fosphenytoin, valproic acid are equally effective and safe, and we still need better treatments for established status epilepticus, and we plan to test ketamine for this role. I want to end by thanking the ESET planning and working group with me, Tom Black, Hannah Koch, Jim Chamberlain, Jim Floyd, Jordan Elm, Nathan Fountain, Brandy Furman, Dan Lowenstein, Shlomo Shinar, Robert Silbergleit, David Kamen, Eugen Pinker. Thank you. Thank you for your attention.
Thank you, Dr. Kapoor, for that. I have noticed there's a couple of questions in the Q&A queue, and we will leave them there until after Dr. Hahn's talk. I'm going to introduce now our third speaker, Dr. Hahn. So Cecil Hahn is a clinician investigator at the Hospital for Sick Children and an associate professor of pediatrics at the University of Toronto. His area of both clinical and research interest are in epilepsy, neurocritical care, and in neonatal neurology. He directs the hospital's critical care EEG monitoring program and also leads patient-focused research among critically ill children, focusing on how we can better understand that when seizures occur during critical illness, how does this contribute to brain injury and neurodevelopmental outcomes? So without further ado, we'll move on to that talk.
My name is Cecil Hahn. I'm a child neurologist at the Hospital for Sick Children, University of Toronto. And it's my pleasure today to speak to you about the treatment of refractory and superrefractory status epilepticus in children. We all know that early treatment of status epilepticus is paramount. In experimental models of status, neuronal injury begins after 20 to 60 minutes of continuous seizures. And we know that status epilepticus becomes more difficult to control as the duration of seizures increases. However, treatment delays are common. The time from status epilepticus onset to treatment is commonly delayed in both pre-hospital and in-hospital settings. In a prospective multicenter cohort study of 81 children with convulsive status epilepticus, the median time to the first anti-epileptic drug dose was 28 minutes, the second drug 40 minutes, and the third 59 minutes. You can see here in figure 1 the Kaplan-Meier curves showing the time from seizure onset to administration of the first anti-epileptic drug in green, second in blue, and third in red. Yet treatment delays are associated with worse outcome. In a multicenter prospective cohort study of 218 children with refractory convulsive status epilepticus, the authors dichotomized children into two groups: those who received first-line benzodiazepines less than 10 minutes after seizure onset, and those who received first-line benzodiazepines more than 10 minutes after seizure onset, termed untimely first-line treatment. In a multivariate analysis, adjusting for other important clinical factors, they found that patients who received untimely first-line benzodiazepines had higher odds of death, greater odds of receiving continuous infusions, and longer convulsive seizure duration. We know that guidelines can improve timeliness of treatment. Guidelines should be evidence-based whenever possible. However, until recently, evidence has been sorely lacking. My institution has recently developed revised status epilepticus guidelines based on new evidence, which I'll share with you shortly. You'll see that this guideline includes early supportive therapy, followed by early administration of first-line benzodiazepine medications within 5 minutes of seizure onset. Lorazepam, diazepam, and midazolam are considered equivalent. If seizures fail to stop within 5 minutes of the administration of the first dose, a second dose of any of the 3 benzodiazepines should be given. Second-line medication options include levetiracetam, fosphenytoin, phenytoin, phenobarbital, valproic acid, or lacosamide. The preferred options at my institution are phenytoin or fosphenytoin, levetiracetam, and in children with febrile seizures or infants less than 6 months of age or presenting with drug-induced seizures, phenobarbital. Valproic acid, although you'll see has equivalent efficacy to levetiracetam and fosphenytoin is not available except by special access in Canada, and therefore not a straightforward option at my institution. If seizures continue despite second-line therapy, the next step would be to repeat the above step with a different second-line medication. Then, if seizures persist, the patient is deemed to be in refractory status epilepticus, and the next step is usually midazolam continuous infusion, followed by transfer to the intensive care unit. Continuous EEG monitoring is recommended at this step in addition to a neurology consult. Until recently, our guidelines for status epilepticus treatment lacked evidence, but as I'll show you now, the last year has brought a wealth of new evidence for second-line treatment of status epilepticus in children. The first study I'd like to share with you was published in May 2019 in The Lancet. This open-label randomized controlled trial was of levetiracetam 20 milligrams per kilogram versus phenytoin 40 milligrams per kilogram, conducted in 30 emergency departments in the United Kingdom. 286 children aged between 6 months and 18 years were treated with either levetiracetam or phenytoin, and the primary outcome was the median time from randomization to cessation of convulsive status epilepticus. This time was 35 minutes in the levetiracetam group versus 45 minutes in the phenytoin group, and this difference was not statistically significant. Convulsive status was terminated in 70% who received levetiracetam versus 64% who received phenytoin. The authors concluded, "We found no significant differences between the two anticonvulsants in any primary or secondary outcomes, including time to seizure cessation and need for additional anticonvulsants. The safety profile was similar between treatments." The next study, published in the same issue of The Lancet, was an open-label randomized controlled trial of levetiracetam 20 milligrams per kilogram versus phenytoin 40 milligrams per kilogram, conducted in 13 emergency departments in Australia and New Zealand. This study enrolled 233 children aged between 3 months and 16 years, and the primary outcome here was cessation of clinical seizures 5 minutes after completion of the infusion. This was achieved in 60% of children who received phenytoin and 50% who received levetiracetam, and this difference was not statistically significant. The authors concluded, levetiracetam is not superior to phenytoin. Both drugs were effective in controlling seizures in 50 to 60% of cases after failure of benzodiazepines. The next study I'd like to share with you is the extension study of the ESET trial in children. This was a double-blind randomized control trial of phenytoin, valproate, and levetiracetam. And this was an extension study that was authorized by the Data and Safety Monitoring Board to allow enrollment of additional children past the enrollment of adults in ESET. This study largely confirms the findings of the previous two studies, the ECLIPSE study and the CONCEPT study, and extends these findings to include valproate. All three anticonvulsants, phenytoin or fosphenytoin, valproate, and levetiracetam, are appropriate first-choice second-line drugs in children with benzodiazepine refractory status epilepticus. This figure illustrates the overlapping probability of success by age and treatment group for the primary outcome, cessation of convulsive seizures. Children are in the top panel, adults in the middle panel, and older adults in the lower panel. And you can see the probability distributions overlap substantially for the three drugs, fosphenytoin, levetiracetam, and valproate. This is a forest plot illustrating the response by age group again. And I realize this is small, but you can see that although the error bars range in size, the overall effect overlaps substantially among all groups. Refractory status epilepticus is defined as a severe form of status that does not respond to first and second line treatment with adequate doses of anti-epileptic drugs. And the incidence of refractory status is quite a bit higher in children than in adults. Although there are numerous treatment options for refractory status epilepticus, there is no evidence to inform our choice of therapy. Midazolam is the most common third-line medication used at my institution. Pentobarbital and thiopental are commonly used barbiturates. They're ultra-short-acting, administered by infusion. At my institution, phenobarbital, administered in high-dose bolus administration, is the most commonly used barbiturate therapy. Propofol is commonly used in adult patients and is very effective. However, caution must be used when using propofol because of the risk of propofol infusion syndrome, which is higher in children. Therefore, propofol is often not used in pediatric centers. And ketamine is an interesting option because of its different mechanism of action. It's an NMDA antagonist, and there's emerging evidence that ketamine may be effective. A number of additional therapeutic options should be considered. Corticosteroids are often used when there's evidence of inflammation contributing to seizures. Plasma exchange, intravenous immunoglobulin, and anakinra are often considered in the context of new onset refractory status epilepticus or febrile infection-related epilepsy syndrome, or if there's suspicion of a paraneoplastic etiology. The ketogenic diet has received increasing attention recently and can be quite effective in cases of refractory status epilepticus, although it is sometimes difficult to sustain the ketosis in the ICU setting. Resective surgery should always be considered when there's evidence of focality, either lesional or non-lesional. And hypothermia has been reported effective. However, there is always concern about rebound seizures upon rewarming. Establishing clear treatment goals during refractory status epilepticus therapy is paramount. There are controversies, such as the right endpoint for titration of therapy. Should it be clinical seizure suppression, electrographic and clinical seizure suppression, EEG burst suppression, or EEG complete suppression? And what should be the ideal duration of therapy prior to weaning? Typically in my institution, it is 24 to 48 hours. One phenomenon that's very important to be aware of is generalized periodic discharges related to anesthetic withdrawal. This is the appearance of generalized periodic discharges during anesthetic withdrawal, typically barbiturate withdrawal. And this can mimic the appearance of seizures, and if not recognized, may lead to re-escalation of therapy when in fact persistence of weaning, as illustrated in this diagram of serial EEGs in a patient, can lead to progressive resolution of these generalized periodic discharges. Prior to weaning of high-dose suppressive therapy, it's very important to optimize conventional anti-epileptic drug therapy. Commonly used medications at my institution include valproate, topiramate, and levetiracetam. And finally, I'd like to conclude with a few important take-home points. As we've seen, rapid intervention for the treatment of status epilepticus is key due to the concept of time-dependent pharmacoresistance. We now have high-quality evidence for both first and second-line therapies for the treatment of convulsive status in children. There is still a lack of evidence, however, for third-line therapies. A guideline-based approach can improve the timeliness and quality of treatment. So it's important to develop your own institutional protocol, and I encourage you to educate your frontline caregivers who will be delivering this protocol to your children at risk. Thank you very much.
Thank you. This is Jaideep Kapoor, and what I'll do is open this session up for questions. The first question please type in your questions in the Q&A box. The first question that I see in the Q&A box is, when ED personnel consider patient having failed benzodiazepines. So I guess this is in context of the ESET trial, and patients who had received adequate doses, and that's as per the guidelines, and they were continued to have seizures, that is, witness convulsions 5 to 30 minutes after receiving the benzodiazepines, were considered to have benzodiazepine failure. So they had to have adequate doses, and you give 5 minutes for seizures to for the diazepam benzodiazepine to work. That was the first question. Second question, again, it is, I presume it is relates to ESET, why children had respiratory depression when they received fosmanitoin. So let me clarify this. The sites were asked to document respiratory depression or not, and they didn't. There was not a significant increase in respiratory depression. What there was a significant increase in was intubation, and that, as you just heard, in other two studies, Eclipse and others, there was no increase with of respiratory depression or intubation with fosmanitoin. So we are investigating this in great detail, and we have not found an explanation as to why the intubation rate was high. We do know that intubation rate in our study varied from hospital to hospital. There are certain hospitals that have a more common practice of intubating kids who are being treated with second-line therapy compared to others which don't. In fact, we found a racial difference, surprisingly, and that related to the hospital population, the catchment area. So we don't know, and considering that other two trials didn't find this, this may be an unusual finding, but it is not respiratory depression. It's just higher intubation rate with fosmanitoin. Let me ask, is there a consideration for using VNS for status epilepticus? Other speakers. Cecil, you want to answer that? Or
well, it's an interesting question. So VNS emergent, I presume you mean emergent insertion of a VNS stimulator rather than use of an existing stimulator. I think we all would use VNS, I think, if it's already implanted to try and assist with aborting seizures. I've never been involved in an emergency implantation of a VNS stimulator. It's a very interesting idea. I don't know if maybe the other speakers have.
We've used it once here in London, but not early on in the course of status. So for a patient with super refractory status epilepticus, we use higher degrees of stimulation early on. I don't have levels for that right now, but I think it was moderately successful in helping to come off of some sedation, but it certainly didn't help terminate seizures and status altogether.
Another question on treatment, and this one is about ketogenic diet in super-refractory status. You want to answer that?
Sorry, I missed the question. Oh, I'm scrolling down.
The question is ketogenic diet an option for treatment of super-refractory status epilepticus?
Absolutely, yes. And we do actually think of ketogenic diet earlier now, even within a day or two of a patient continuing to seize, we'll often try and initiate the diet and have had some success. So I encourage people who have the resources to consider the diet early.
So another question is about brivitiracetam and perampanel for as second-line agents for treatment of status epilepticus. I can tell you that they are perampanel. They are planning a clinical trial. I do not know whether it will be for second-line therapy or third-line treatment of status epilepticus, but perampanel trial is being considered. My personal bias, and I'd like to hear other speakers say it, Briviact is just another form of levetiracetam and another anti-seizure medication. I'm not sure if it would be any more effective than what we already have, but you all can answer that question as well.
So we've used perampanel quite a bit in super refractory status epilepticus, but it hasn't been one of our earlier go-tos. So I'm not sure if you're already in the area of diminishing returns, but it's been relatively well tolerated. I've seen one patient with liver enzymes that went up after we started it relatively rapidly. As far as brivaracetam, usually we use it if there's poorly tolerated side effects from the levetiracetam, and so I haven't used it before levetiracetam yet.
There was a point which I think is worth addressing. There is a mistake in my slides actually with the dosing of the levetiracetam versus phenytoin, which should be obvious to those of you who've used the drug. So they're switched in a couple of the slides, so I apologize for that. The guideline though is correct that I showed you.
So another question about a refractory status epilepticus. If in third-line treatment after reaching maximum dose, say for midazolam, how long do you wait before starting another treatment?
I don't think we wait much at all. I mean, I think midazolam is so short-acting, you should see a response right away. The other important thing to point out with midazolam is as you're titrating up, you need to give bolus doses in order to achieve steady state quickly. So usually you bolus and then increment the dose. If you do that, you'll achieve a steady state within 5 or 10 minutes. If you don't see response, we move on to the next agent. Much more commonly, we see escalation of midazolam too slowly. So it'll take, if you're actually watching the EEG, I encourage people to actually go down to the bedside and work together with your ICU colleagues as you're titrating these therapies, because you should be able, if the patient continues to seize, you should be able to get to maximum midazolam within an hour or so.
Another question that came up, and we've struggled with it during the trial, so other panelists can answer. Should you use second line agent? And Tanal, you can go first and Cecil second, and then I'll give you some bit of evidence that we will publish in a few months from our trial, which is very surprising.
So usually if I haven't had success with the first second line agent, I often do move forward with a second line agent while we're giving a continuous anesthetic. I don't think that's evidence-based yet, but I'll be interested to hear what comment you have to make afterwards.
Cecil, what do you do?
Well, if you look at the trials, I believe both the CONCEPT and the ECLIPSE trial did publish, at least one of them published the crossover data and
yes.
showed there was additional benefit of giving the opposite drug. So I think there is some evidence in children. It wasn't their primary outcome, but I'm very curious to hear what you have to.
So we in our protocol, we left it open, and pediatric neurologists especially prefer to use a second line agent. In fact, you see kids have a lower intubation rate than adults, about 8 to 10% compared to adults, 25%. But the emerging data, and please don't quote me because we haven't, this hasn't gone through peer review yet, but what we are finding is that patients, when they were treated with the drug that they were at home, didn't respond as well as the drug that if it was different from their home medication. So we are analyzing the data on all the patients who had epilepsy and were on anticonvulsants at home, and early non-peer reviewed and evidence seems to suggest that if you were on LEV at home, you don't respond as well to LEV, you respond better to other drugs. And if it is true, then I would be I would be thinking of at least trying one other agent if from whatever you've used, which starting the trial I wasn't a fan of. But if the evidence proves to that way, then it may change practice. But we are still analyzing data. This is right now we're not quite sure if that's really the case, but we'll publish it and then you all can see. How do you distinguish, on EEG, how do you distinguish periodic discharges from seizures during withdrawal? This has become this was a problem with that neurosteroid study, trying to figure out whether it was a seizure or just withdrawal phenomenon. So how do you deal with that?
Well, I'll talk first since I mentioned it in my talk.
Yes.
So I think it sometimes you don't know until you just keep pushing forward or withholding therapy, and over time it will be obvious. I think there is this continuum between periodic discharges and seizures, and sometimes it can be hard to know for sure. But I think they will declare themselves. I think the other thing to look back at is the previous pattern of seizures, and that will usually reemerge upon anesthetic withdrawal, and that's really what you're looking for, I think, as a sign of seizure recurrence. If you're seeing a different pattern with periodic discharges, it's important to, I think, not assume too quickly that this represents a seizure, and to give yourself some more time and see if this pattern actually continues getting worse or actually gets better, as I illustrated in the slide.
I don't have anything to add to that. Yeah, fully agreed.
So other question relates to corticosteroids in treatment of refractory status. Where do you all put it?
So if it's a refractory status where we're concerned about an autoimmune etiology, I try to use it really early on, but I wait for LP and ruling out any infectious cause as a possibility, because we could make that worse with pulse steroids.
So do you have does everybody who have refractory status get steroids if they don't have infection?
So I would say if there's no clear etiology for the steroids and I'm concerned about autoimmune etiology, then yes, absolutely.
So there are questions about neonatal status. Do you use perampanel?
I've never tried using perampanel in a neonate, but I think it's interesting to hear that there is a trial being planned for perampanel. Obviously, it's a very different agent from the ones we have, and so it certainly would be interesting to see if there's a signal there.
There's a question about lacosamide to be used in status.
Absolutely, there's a trial actually of lacosamide for the treatment of status. The TRENDS trial, I don't know if you're familiar with it. It was a trial actually not so much in status, but in the ICU setting for seizures in critical care. And that trial showed that lacosamide was similar to phosphenitrone in its efficacy. So I think there is certainly a potential role for lacosamide. The evidence in large-scale trials isn't there yet, but I think it's available IV, and certainly is a potential agent. You do have to keep an eye on the heart function, though, with lacosamide, heart rhythm.
So I think we are almost out of time. There is a networking room. Tanel, guide us. So there's a networking room that we'll join, and if you have questions there, we can answer them. But I think it's 2:15, so I have to stop, right?
Yep, that's correct. I believe the link is on the main meeting website for the networking rooms.
So we'll be there. Thank you everyone for joining us. And thank you for all those insightful.
Thank you.
Thank you.
Thanks for the good questions.
So I think we leave here and try go to the networking room.
How do we get to the networking room? Do you know?
I think you have to go to the main website, and there's a link in your email for that.
Oh, okay.
How do I get into the networking session?
So can you see the screen?
Yeah.
So if you click in here to the networking, there will be a meeting with the time for now that you can click in to join the link.
Yeah, it's not doing anything. That's what I was. Go to the.
For anyone who would like to join the networking session, if you go to the main Congress platform, which is NAEC2020.ipostersessions.com, the link you will have received in your registration email on the homepage, which is what you're seeing on the shared screen right now. If you click networking, it will bring you through to a gallery of options, and you click the current one, which will bring you through to a Zoom meeting room where the current networking session is happening. Right. So if you go to NAEC.com, click the networking link on the landing page, and then click through to the current networking session. You will join the meeting room where that's happening. Thank you.